Cue the intro music. Yes. Welcome everybody back to the next installment of the Many Minds podcast, where we encourage collaborative community care using many minds for better outcomes. I am Alex Davis, physician assistant. I've got along with me Tyler Murray, nurse practitioner, and the two of us work together at Summit Brain, Spine, and Orthopedics in Lehi, Utah. The point of the podcast, as always, is to promote interaction between the specialties. We want to dig into what makes your specialty special. We're going to talk about some of the stuff that we may not always get to talk about as healthcare providers. What's life like in your shoes? How can we better support what you're doing and help us all provide better care for the community?
And with that, the general disclaimer is that this podcast represents the opinions of myself, Alex, and any guests that we have on our show. The content from this podcast is not intended to act as a substitute for professional medical advice, diagnosis, or treatment. We're just here to talk and have a good time. And with that, we'll jump into this week's episode. So today we're going to dive into the world of interventional radiology. And our guest today is Aaron Hewlett, and he is a PA and has been in practice for about 4 years. Am I correct in that?
Yeah.
With that, I'm going to pass the baton over to you to let you kind of give your bio, background, kind of tell us who you are and what you're involved in.
How'd you get to this seat today? How'd this happen?
Oh, the stars aligned. I'll start out with that.
Love it.
Rocky Mountain University, I think that's maybe
That's been a commonality. We can't shit away from that.
Alex needs to branch out a little bit more.
Yeah, right. Yeah.
I grew up in Centerville, Utah, and then ended up going to school at BYU and then UVU. Graduated from there, went to PA school at Rocky Mountain. Before I got into PA school, I come from a family of total business. My dad's an accountant. Both my brothers were in the business school at BYU. So medicine was just, no one does it. So
You're the black sheep.
Right?
Pioneer.
Yeah,
all the pioneer.
Yeah.
Okay, yeah.
That's right. Middle child, black sheep. It all aligns.
fits. Yeah.
So trying to find, PAs to shadow was so hard. I mean, it was so difficult. So, when you guys said you were doing this podcast, I thought, oh, this is perfect to at least get people, who even want to go into PA school or NP school to, maybe get their foot in the door with someone that they can chat with and ask some questions.
Yeah.
I remember I went through the other day to give an accurate number. I messaged like 68 people on LinkedIn that were all PAs, NPs,
goodness.
just to try to, get some information of if they liked it, what they did, if, should I do PA school? Should I do med school? It seems like everyone who goes to PA school or PA school or NP school at some point kind of wonders, well, should I just do med school? Anyways, so funny enough, Sarah Mendenhall, the one who was on a couple weeks ago, she was one of the two that responded of those 68.
Oh, yes.
Yeah,
I'm glad to hear.
So thank you, Sarah, if she ever hears this.
Yeah.
Anyway, so finding people was really challenging, and I just say that because if anyone wants to reach out to me, I am more than happy to answer questions, because it seems like it can be hard to just get your foot in the door. If you don't know anyone, you don't come from a background of medicine, it seems like it can be challenging.
Yeah, absolutely. We've started in our office kind of a great idea, and I'm sure there's a history to where it came from, but a position in our office, they're called patient care coordinators, which fills the role of what would be like a scribe or an MA, and they kind of have a hybrid doing both in our office. And they're all these prospective med students or PA students that are in college for that exact reason. They're looking for some way to get exposure, get some shadowing, and then it helps them in that way, but it helps our office in that they're energetic, they're hardworking, they're motivated to have the experience.
Yeah.
So they come into the office and can work hard and create a great atmosphere. And it's been a great relationship.
That's awesome.
And about 90% or more are pre-med. They want to go into medicine, become physicians. And I'll tell you, there is a PA in our practice that is hell-bent
pushing hard
on making sure that she emphasizes, you don't want to go to med school. You should become a PA. PA is the route to go, or NP.
Yeah.
And I love seeing it, because you do see a couple of them that are like, they think about the advanced practitioner role and what that can be, because they get to see us in our environment and what we do.
Sure. Which
is maybe a little unique, maybe not. We're going to find out kind of through your lens what you do and what happens there. But I don't know, it's just fun to see, and we have a lot of fun.
Totally.
And in the pre-med students that go on, I always joke with them. I'm like, well, when you become rich and famous, just don't forget me. You know,
that's the little guys.
Yeah,
you
don't
taught
forget
them everything.
Yes, remember who taught you something.
That's right.
So what was it in your experience then when you're doing these shadowing hours and getting into it? So how did you end up with PA?
So it was pretty funny. So I had 3 knee surgeries when I was in high school. So that's kind of what it seems like everyone has some sort of experience, right? That kind of introduces you to medicine at, you know, when you're younger. So they were all in high school. Of course, the doctor that the orthopedic surgeon up in Salt Lake, he kind of put the thought in my head, which was funny because he didn't even have a PA. He said, "Yo, you're interested in medicine? Oh, maybe you should look into PA school." I was like, "What? What the heck's PA school?"
Yeah.
So he's kind of the one that planted the seed of what PA school even is. Anyway, so fast forward to college, right? And then you start to go, okay, well, I've got to take chemistry. I've got to do all these things, which was so foreign to me. And so I actually took, you know, Chem 105 or Gen Chem 1. I took that 3 times, the first 2 weeks, and I would drop, you know, you have that 2-week grace period.
You can get your money back.
You can get your money back.
Yeah.
3 times in a row, and I would take it, and I'd be like, there is no way I can do medicine. I would drop it three times.
Yeah.
So anyways, what I did, my dad still gives me such a hard time because he's an accountant, right?
Yeah.
So I thought, you know what? I don't think I'm, you know, fit to do med school, or not med school, but just medicine in general. I'm not fit to do medicine, so I'm going to switch to do business.
Mm-hmm.
So the next semester I signed up for accounting, I signed up for marketing. I did all of these, just total shift, like, well, you know, these ones are quote unquote easier, which wasn't true, but anyway, so I took those and I hated every second of it. I mean, I couldn't stand it. So sure enough, and my dad gives me the hardest time because the first couple weeks, you know, I was trying to sell myself on it. I was like, "Dad, this accounting stuff is so cool." And he's like, "Really? You've never been interested in this stuff?"
Yeah.
Anyways, then sure enough, like towards the end of the semester, totally hated it. Could not stand it. And
you couldn't convince yourself.
Could not convince myself, no matter what I did. So then I finally, you know, bared down and I said, well, I've just got to figure out a way to, you know, to do chemistry, to do anything to get my foot in the door into medicine. So anyways, it was a pretty funny shift. And then sure enough, I feel like, you know, everyone does it. I'm not nothing special, but you just kind of put your head down and figure out how to study for those classes, chemistries, OChem, all that. And then just kind of made my way through. And anyway, so then the decision to go to PA school, you know, was kind of made of when I just kept talking with Sarah. She was one of them. And a couple other PAs that said that they really liked what they did. They felt like they had a good work-life balance. And I also talked with a couple of physicians. And, you know, again, it's total opinion. Everyone's got their opinion on what is right, or, you know, depending on what your philosophies are and what aligns closely with you. But there were some physicians, interestingly enough, that said, you know what, I think I would go to PA school if I were you. So anyways, ultimately decided that for me and my wife, I got married when I was 21, she was 20, so we're pretty young.
Yeah.
So I felt like we made that decision together to do PA school. Anyway, so I'm going into too much detail about deciding what I even wanted to do, but, you know, I recognize it can be challenging, right?
Oh, yeah.
So we finally made the decision, and then went to PA school. And then how I got my foot in the door into interventional radiology was one of my cousins, her husband is an IR doctor up in Idaho Falls. Dr. Priest is his name. Anyway, so I reached out to him. I said, hey, I've, you know, kind of been interested in what interventional radiology is. Can you talk to me a little bit more about it? They don't have any PAs or any mid-levels there. And so anyways, fast forward, they said, oh, maybe we could use some mid-levels. So when I finished PA school, that's where I moved up to.
And you were first one.
First one. Yeah.
Wow.
Yeah. They interviewed me. I actually did a rotation with them.
Yeah.
Totally loved the group, loved everything that they did. And, you know, and they were building the program, which was kind of challenging, right? What's the mid-level going to be doing for us?
How are they going to utilize you?
Oh, yeah. I mean, there were some insane growing pains there, but also it was so awesome.
Kind of cool to blaze a new trail, I'm
totally.
sure. Yeah.
Yeah. I mean, it was at one point one of the hospitals there, the what do they call it? The head doctor over the hospital. He didn't want to approve it, right? He didn't want to approve having mid-levels work in IR. He said, you're going to have mid-levels do lumbar punctures? You're going to have them do, no, there's no way. anyways, after working on him, these these IR docs finally convinced him that, look, like, they're going to be watched. We're going to train them. And so anyways, it ended up working out. But yeah, blazing the trail was quite interesting. They hired me and actually another one of my buddies from Rocky Mountain University.
Mm-hmm.
So we both got hired there. And then I worked for them for about 2 years. And holy cow, I mean, it was such a learning curve.
Tell me about this, because you and I caught up a little while ago, and I was blown away at the stuff that you actually do day to day. It's all hands-on physical skills.
Yeah.
And you don't really get that in an educational setting in school, right?
Right.
You can learn the medicine and learn the science, but actually getting your hands dirty and getting proficient at the skills is not an easy thing.
No, totally.
How did that kind of training go in your work setting?
Yeah, so again, because we were so new and we were the first mid-levels that they'd ever hired, it was kind of a learning process on both ends. They implemented this kind of really heavy curriculum that we had to do. We had to observe 15 to 20 procedures of, each of these minor procedures, and I can go into, what we do.
Sure.
But they would have us observe 15 of them, and then we would perform 15 of them.
I thought it was watch one, do one.
Yeah, right. Yeah, that's what we
one,
kept
and then
saying.
You're good, right?
Well, I mean, we wanted to as bad as we were just like, oh, come on, we want to do it. But, they recognize that the stuff that we do in IR is mid-levels. You just don't learn in PA school or NP school. So, of course, you learn what things are, right? Spinal tap, a lumbar puncture.
Sure. Kind of the basics of what it involves.
Exactly. Yeah. But you don't learn the actual hands-on skills. Uh-huh. So anyways, they were really good at having us do that, and we had to record everything. It was kind of stingy with how tight they were on everything. Do 15, perform 15. Then those physicians would meet as a group, the IR doctors, and they'd say, do we feel Aaron can safely perform lumbar punctures without, us being in the room?
Right.
And so it was let's show you one and go, do it. It was a really intense training process.
Gotcha. That's reassuring, though, for everybody.
I was going to say, I think I would have preferred that in that setting, just because that's an eloquent area that you're working in, right?
Totally.
So, absolutely. The most that you and I do, our hands-on skill set involves suturing maybe?
Yes.
Which is a pretty basic hands-on skill. And even still, I will admittedly say not the easiest thing.
It's
honestly.
Not. Yeah. So you think about more of the complex stuff. Yeah. I'm actually, that's awesome.
Yeah.
And that's cool that they took the chance. Like they were like, hey, let's try this. But my question to you is, was there a need? Was there like an excess in volume? Like they weren't able to get, enough, the supply and demand kind of question?
Yeah, totally. So the whole idea of having mid-levels in this radiology setting is, overarching theme is let's have a radiologist who, normally would be doing, let's say a lumbar puncture. I keep using that example. That maybe takes, 30 minutes. Let's have a mid-level go in and perform that same procedure so that I can have that same radiologist who normally would be doing that, I can have him sitting in the room reading more films, MRIs, whatever it is. And it's, multifactorial. Of course, it makes them more efficient because they're not having to get interrupted and get out of their seat. And they can just crank through, this big, never-ending conveyor belt of images and studies that keep coming up. And so it was multifactorial. Let's have a mid-level do that. I can then, read images. But the best part of my job is I feel like that they are always available, right? Because they're always there on site.
Sure.
And so if I ever, I'm troubleshooting through things, I can't seem to get actual CSF coming out for the lumbar puncture, I can just say to one of the techs, hey, can you go grab Dr. So-and-so? And in 2 minutes, they'll come right in. Hey, what's going on? Mm-hmm. And so that reassurance that they're still there. But yeah, that's why. That's why it was really beneficial to them. And then now, so we started with 2 PAs there in 2021, and they are up to 6 mid-levels now.
That are with their practice.
So they bought in.
Totally.
High five to Aaron.
Yeah, no, I don't know about that.
You pioneered this.
No, it wasn't. It wasn't me.
When's your book coming out?
Yeah, right. It was honestly them. Being willing to take the chance, right? Because he had all these people that didn't want, but didn't necessarily believe the process of how it would work. And so anyways, the doctors there, I could never thank them enough because it's such a huge learning curve, and for them to take the time, I mean, and you've all mentioned it before.
Yeah, for sure.
The investment of a mid-level, it's huge.
Yeah.
And I think there's other ways that, even money-wise, you can't quantify that it really is a big investment.
With the money situation, I am interested to know, when you first started being the first one, what was that conversation like salary-wise? Like, or money-wise? Was it an hourly thing? Was it they were just going to pay you the standard, see how things go? What did that look like?
Yeah, so they were really good to work with because, so one of those doctors, Dr. Priest, who I keep alluding to, so he actually was at Duke the same time that one of the IRPAs who works down here in Provo. So they knew each other, right? They knew each other at Duke, and so of course they went their separate ways. He's now in Idaho, and Cody's his name. He works here in Provo. Anyways, so Cody was actually maybe going to join that group, and so he'd already been working for 10 years in IR, so he had an idea. So they actually asked him, and I don't know if they paid him, but basically said, what's your structure like? We don't want to overpay, but we also don't want to underpay. And so he thankfully provided them kind of an
industry standard.
Exactly.
Yeah.
And so, after going back and forth as a new grad with them, we were able to come to an agreement, and I felt like it was really fair. So yeah, that's kind of how it went. Thankfully, it turned out good.
I always think about that back and forth because as a new grad, I think it was more of, you have a job? I accept.
Yeah, totally.
Totally.
I don't know. But
play it cool.
Yeah, play it cool.
Yeah.
Yeah, because, it's a jump. You go from being in college to then accepting your first job. And, hindsight now, it's like you can make six figures. And unfortunately, nowadays, it's not enough.
Sure.
But at the time, you think about, yeah, that's a big deal if you're even close to that. So, yeah, it's interesting.
That's always a funny scenario. I remember that. You feel like you want to have some bargaining power.
You go in with all the best intentions.
All the best intentions, and then ultimately they hand you a contract, and I'm going to act cool, take it back, and sign it. Yes, let's go.
Totally.
Do it. Yeah.
And the funny thing was, I had several friends, right, that, when you near the end of PA school, that they're starting to get contracts, and they had all just quickly signed, and, I thought in my mind, well, God, like, why don't you go back at least once? And they would all say, well, what are you going to go back with? You don't have experience.
Yeah, exactly.
I said, well, I don't know, try something. And so with them, my
family's in business.
Yeah,
Come on, I got to lean on this a little bit.
Exactly. So yeah, it worked out.
Awesome.
So, I will say a plug to, always at least go to bat for yourself. What's the worst they can say, right?
Yeah.
No. All right.
Yep.
Well, then I'll accept whatever it was.
And that's the experience talking, like having been through that. So the people that are listening that are thinking about doing that, that's definitely food for thought. Like
Totally.
Go in there and not be a little bit vulnerable. Yeah. Ask questions,
And it's hard, right? It's really hard.
Super hard.
And,
Easy for us to say because
Totally.
we're in this situation, but.
Totally.
Yeah.
But, know your value.
Yeah. I love that.
So tell me a little bit about your day then. What's your day like now that you're into the career? It seems like you've got a handful of years behind you now and pretty well established. What is the day-to-day like? What's interventional radiology like for us providers, practitioners in other settings, maybe not as familiar with it?
Yeah, so there's kind of two different settings. We work in the hospital setting where we're doing procedures, but we actually have a clinic. It's called Interventional Vascular and Vein Center in Provo. So we've got 7 mid-levels, and 4 of us rotate through that clinic. So in the clinic setting, we're seeing outpatients, right? We are seeing patients that are coming in for peripheral arterial disease. We're doing venous insufficiency workups. DVTs is kind of one of our bread and butters. And also like pelvic congestion syndrome. So we're working patients up. We're also seeing follow-ups after vein treatments. And then in the clinic setting, we're also actually performing some ambulatory phlebectomy. So the big bulging veins, we numb up the skin, make a little incision, then actually pull out the bulging veins. So us mid-levels are doing that. We also do some of the sclerotherapy. So it's where you inject medicine under ultrasound guidance into those superficial veins. It irritates the endothelium, scars that vein down shut. And then, the idea is let's get the blood to flow through those deeper veins that are flowing just fine. So anyways, in the clinic setting, we are there 4 days a week. It's 8 to 5, kind of your typical clinic setting.
How many procedures or patients in a day?
Yeah, so thankfully they have our procedure day. designated as strictly procedures, so we can just kind of crank through procedures.
Yeah.
So that one, we get there around 7:30, and then we're done usually about 3:30 or 4.
Is that, in that clinic setting?
That one's in the clinic setting.
Interesting.
Yep, where we're doing those procedures. And, those can range, right? If people have got just a couple little bulges, that procedure where we're taking out those veins maybe takes about 20 minutes. Mm-hmm. But then there's some patients who I'm sure everyone's seen who's just got these gnarly veins all throughout their legs, and you've got to do the whole leg. So sometimes you're in there for, I think the longest time I've been in is 2.5 hours.
Oh my
where,
goodness.
You've made, I think the most that I've counted was about 95 little incisions. You're not suturing these, you're just putting steri strips over them. So anyways, that's kind of what you can expect in our outpatient setting in the clinic.
Yeah.
And then in the hospital setting, it's about 8 to 5 as well, and we are just performing minor procedures all day. I get asked mostly by family and friends, like, well, what the heck is interventional radiology? What's IR?
Yeah.
The best way to describe it is it's image-guided procedures, right? So we are doing fine needle aspirations of the thyroid under ultrasound guidance. So learning how to use an ultrasound and actually watch your needle, that was probably one of the hardest skills to pick up. It just takes so much practice.
Yeah.
And the people that do it make it look so easy.
Oh, they do. Totally. Yeah,
I've seen it, and I'm like...
Obviously, this black, gray, white line is this structure.
Yeah.
Obviously.
Yeah.
Yeah.
And it's just this crazy process where, I remember being scared spitless when they kind of gave us our list up in Idaho. They said...
Of your procedures, you gotta
here's
get
the
down.
procedures, and they had different tiers kind of with difficulty level.
Yeah.
And I remember looking at half of tier 2 and like all of tier 3, and I was like, there's no way. There is no way I'll ever get comfortable enough where I can stick a needle in someone's neck and not poke carotid, right?
Sure.
Yes.
So it was a really steep learning curve, but that's what we do. So we do a lot of minor procedures.
What are the most common ones?
So fine needle aspirations of the thyroid's a big one. Paracentesis and thoracentesis, that's where you drain fluid off the abdomen and also off the chest cavity. Lumbar punctures is another big one. We do a lot of ultrasound-guided biopsies as well. So if people get sent to us, they've got an abnormal lymph node and they're growing, armpit, wherever it is.
Yeah.
Under ultrasound guidance, you get a needle in there and get a sample of it.
Yeah.
What's the highest risk procedure you're doing that you still are like, I get a little nervous doing this one?
Yeah, it's funny. I thought that the other day. I thought, God, it feels like in medicine, the second you get comfortable, I always joked with my buddy up in Idaho. I'd always say, whenever you start to get comfortable, the IR gods will strike you down, because you'll have what's normally a, crystal clear, straightforward procedure. And for whatever reason, it will just go totally sideways. Of course, in a minor way, because it's not like we're doing anything crazy. Yeah. But, you have a lumbar puncture that you just cannot get into because you have a crazy osteoporotic spine, and you just can't seem to get your needle to get in there. So as far as, highest risk, I'd say bone marrow biopsies. It's probably also my favorite as well. So we're getting samples of that posterior iliac crest on the hip, and we use moderate sedation, so we kind of get to run the room, and so you're, of course, all sterile, and it's probably my most exciting procedure where I feel like, hey, this is pretty dang cool.
That's awesome.
Yeah.
Very cool. What's kind of the patient population, I guess, that you interact with? Because it sounds like you're all over the board.
That's what's crazy. It is literally everyone. So we also do, barium studies. So we'll do swallow studies, right? And we'll do it on NICU babies, right? Where they're trying to see, are they aspirating or not? And so, we run the machine. We have someone that gives them the barium orally. And then we're trying to get it positioned just right to make sure that, we can prove or, disprove that, hey, they aspirated on that.
Yeah.
So to answer your question, we work with this population of NICU, babies, all the way to people in their 90s that are coming in for, different things, whether it be paras and thoras. It seems to be the most common for elderly patients. So then you're dealing with inpatients, right? You get people that are doctors that call us and want us to do a consult on, I had one the other day, a vertebroplasty. So where we're doing the consult, vertebroplasty is where they, essentially are injecting cement into the vertebral body to solidify the fracture.
Now you're speaking our language.
Yeah, right.
Yeah.
That's right. That's your guys' ballpark.
I've heard of that one.
Yeah, right. So we'll do consults on those. I just did one the other day. So it's kind of a mix of everything. It's hands-on. It's also interacting with patients and, doing consults. So
all the different providers and specialties, I'm sure you get to chat with as
kind of
well.
all of
So
them.
you're
We'll go down to the
board.
ED. I'll go and do a bedside procedure, a thora in the ICU for a patient that can't really move. So you're kind of all over the place.
When you go in that setting and you're introducing yourself, I mean, do they know, the patient that is, that you're an advanced practitioner, or is it kind of just, I mean, and what's the kickback? Do you get any with that? Is there any concerns from the patient side of things?
I'd say very rarely. Of course, it's happened a couple of times. Everyone always asks me, oh, well, do you, because I ended up getting my doctorate. I didn't mention that. At Rocky Mountain, I did do the doctorate program, so sure, I have a doctorate degree. So everyone asks me, friends and family, well, do you, introduce yourself as Dr. Hewlett? I say, no, just call me Aaron.
I'm Aaron.
So my phrase is always, hey, my name's Aaron. I'm one of the PAs that works with the radiologist. This is what I'm, here to do. I explain it to them. I've probably had less than, 5 patients say, oh, I'm really not comfortable, having a PA do this. And I say, totally fine. I explain it and I say, if you'd rather a doctor, I'm totally fine. I mean, that's your right.
Yeah, for sure.
And so I almost all of them, except for one, the physician that was with me actually came back in and,
he's done a lot more of these than
right. That's exactly what they start saying. Well, I'm just letting you know, yes, I'm the physician. I can stay in here and watch her and do it, but he does 5 of these every day, and I do 0. And I've done 0 for the last time.
That feels good too.
Yeah, right.
Yeah,
Totally.
It feels so good.
So
sometimes people, I don't know that they know what they're asking for.
Yeah.
In that scenario.
Yep.
But
I agree with that. Yeah, and and they have their right. So I never deny them of that. If someone wants to see a doctor, totally fine.
Yeah.
Can't say I would be completely different in their shoes as well.
Yeah.
One thing that I hear about interventional radiology, at least I have heard from other colleagues that have been involved in that, is a little bit of a difficulty with the call schedule or the after hours things, because you do need to be available. That service you're talking about treats everybody, everywhere, all the time.
Yeah.
It needs to be available.
Right.
How difficult is that for you with the late stuff getting called in the night or the weekends and things like that?
Yeah. So thankfully, we've got 7 mid-levels, and we are on 24/7. One of us is on 24/7. And so between the 7 of us, it's not too heavy. You feel like you have a decent rotation where, it ends up shaking out to be at least how things are right now, where I'll take 3 weeknight calls, in a given month. And then it, of course, is about every 7th weekend where you're on from Friday morning until Monday. They're a little bit painful, especially when you're getting called in at 3 a.m. to go do, seems like lumbar puncture or joint aspiration are the most common ones that we get called for, in the middle of the night. But thankfully our group compensates us. We have a base pay and then we get some call pay on top of it. So, I feel like all of us that go in the middle of the night, you kind of think, well, remember, I'm getting paid. I'm getting paid more.
Sure.
So it hasn't been too bad. Yeah. I know you had mentioned at the beginning, kind of curious about ballpark for salary.
Yeah.
So I feel like starting out in the interventional radiology world, you could expect around the 120 range. And then just depending on if you take call, you can obviously make a little bit more. Mm-hmm. Up in Idaho, they didn't have us taking call, but of course it started to develop where they realized, hey, we could have a PA do this in the middle of the night, not me.
Yeah.
So, they start to buy into that. And I just heard that they made it, mandatory call up there. So, it feels like everyone, no one's immune.
Yeah, of course.
So yeah, 120, I'd say if you're kind of coming out of school. Of course, it's, as we all know, very dependent on where you live. But here in Utah, I think that's pretty reasonable.
Oh,
and then I'd say the upward end of, if you've got a lot of experience, I'd say in the 170 range is what you could expect.
Gotcha. And it's a fair balance, it sounds like, for you then. So you feel like when you're at work, it's a reasonable workload. The timing's okay. You get enough of your own time and free time, and
yeah, totally,
it's not too burdensome.
Totally, yeah. I feel like it
doesn't sound like a bad gig.
Right, exactly. I'm so biased. I think we all are with our own specialties, but I feel like I've got the best specialty there is. because it's so hands-on, but you also get this massive variety, right? Even the variety between hospitals. We cover all the Utah County IH, Intermountain Health. There we go.
Yeah.
All the way from Spanish Fork, up to American Fork, and then of course Utah Valley. And then we even occasionally will go up to Park City and Heber and cover those hospitals.
Oh, wow.
So even, the variety that you get between the hospitals, let alone the, procedural things that you do, I just love the variety. Someone asked me the other day, well, what's your favorite, rotation to go to? Is it American Fork? Because that's, I live by American Fork Hospital. So, I think I'd go crazy if I had to just do one. Like, it's so fun to just get to rotate through all of them. So, yeah, to answer your question, it's a pretty good balance, I feel like, where we get to rotate around, but also get a wide variety of procedures that we get to handle.
Very cool.
Do you feel like in the hospital settings, are you interconnected with the other disciplines? Like, have you gotten to know them? Do they know you? And what's that experience been like?
Yeah, for sure. I think that it just continues to grow. Of course, I've been with these guys for about a year and a half. It seems, so we've got a couple of PAs that are in their 50s, and they know everyone, right? I mean, they've been there for so long. But yeah, we definitely will interact with ICU doctors or, mid-levels. Just the other day I had, in medicine, I feel like you never really know, how did they get my cell phone number, right? I think we've all had that where you look, you're like, who the heck is calling me? But I'm on call, so I answer, and hey, my name's so-and-so. I'm one of the trauma mid-levels. Oh, cool. What's going on?
Yeah.
Anyway, so yeah, we definitely get to interact with others,
cool.
And it's fun when you start to get to really know them. And one of my buddies works in general surgery at Utah Valley, and so he'll text me and say, is it you that's on call today? Please say it's you. I'm like, no, I'm not there. Dang it. It's just an easy phone call and no intimidating, I've got to, really present my case to Aaron. And no, just, hey, this is what's going on. Can you guys do it? I don't know. I'll chat with our doctor, let you know. So yeah, we do get to interact with,
cool.
other specialties, which makes it fun.
And what is the ratio right now with your mid-levels that you're working with, NP to PA ratio?
Yeah, it's about split.
Is it?
Yeah, so we've got 4 PAs and we've got 3 NPs.
Yeah.
So
I just wonder how the word's getting out, because I think about when I was searching jobs, and maybe it was just the timing of things, like you didn't see a lot of interventional radiology postings that I recall. So people finding that niche and being able to get into it, hopefully it's becoming easier and easier, and getting the message out there.
This guy's doing it. He's starting programs.
He pretty much just
Idaho.
pioneered.
I know.
It can definitely be hard to get your foot in the door, in the IR specialty. And I think it's probably because it's just such a huge learning curve, right?
Right.
You're doing x-ray or fluoroscopy, you're doing fluoro-guided procedures, you're doing ultrasound stuff. So, if you have a candidate who's got at least some experience, seems like, they're way more willing to pick someone like that who the training period is going to be a lot shorter, as opposed to, punk Aaron coming out of PA school that knows nothing. I mean,
that's exactly it. I think about, when I was a nurse, I worked on a neurosurgical unit, and I took care of the patients now that I'm, working up and assisting in surgery with. But at that time, I didn't look at any imaging.
Yeah.
And then my schooling didn't anyway, prepare me enough to know all the ins and outs of radiographic, stewardship and being able to know that in and out. And it wasn't until I got my hands on and just started watching people and the repetition of things, and that's really where your experience is gained. But you got to have somebody willing to take you on and do that. And so I'm glad you found that. That's great.
Yeah.
And hopefully those that are interested in any specialty, that's exactly what you find. But you got to put yourself out there and take a chance, and hopefully they'll take a chance on you. So
totally. Yeah, I feel super lucky. And then of course it's the classic conversation of, if you're from Utah and you want to work in Utah, and let's say you're die-hard wanting to work in IR, maybe you got to be willing to move out of the state for a little bit, right?
Sure.
That's
it
good
was
counsel,
so, my credit forever goes to my wife, because ultimately we made that decision together. Hey, because I had a couple of job offers out of school to work in Utah. You get to stay where we're at.
It's comfortable, it's safe.
Yeah, exactly. Yeah. But it wasn't anything that I loved to do. And so, I will always be grateful for my wife when I remember the day that we've, finally had to decide, are you okay moving to Idaho so I can work in this specialty? And I'm grateful. She said, yeah, I don't want to, but I will.
Yeah.
And so we thought we'd be up there for, I don't know, you never know, 5 to 10 years. But sure enough, it ended up being, 2 years. And then we got back to Utah.
Very cool. One thing we like to finish up with, we're getting towards the end here. We love story time. Can you come at us with one of these interactions you've had that was your favorite memorable patient experience?
Yeah, totally. So, I've listened to a couple of your other podcasts and I thought, man, what am I going to say? And sure enough, like I worked in the clinic, I don't know, it was a couple of weeks ago. And after I walked out of the patient's room, I thought, this is it.
That's the one. Oh, good.
So it was this lady who came for a DVT follow-up, and sweetest lady. She just very, very kind. She's a little bit older. But anyways, we have interval follow-ups when we follow up for DVTs, where we do an ultrasound and then kind of chat about, what are things you're doing and to try to help it to, clear up. Things like wearing compression stockings and being active are things that can definitely help. And of course, anticoagulation, right?
Yeah.
Eliquis being kind of one of the biggest ones. So sure enough, she was there for her month follow-up. So we did the ultrasound. She still got, quite extensive clot all the way from the groin down to her ankle. It really wasn't bothering her that much. So I said, well, have you been taking your anticoagulation? And she's like, I did for a little bit, but no, I'm not. I'll be honest. I said, oh, well, thanks for being honest. You know what? So are there things that you've been doing or that you've found that seem to be helping? She goes, yeah, I actually have. I said, oh, tell me. She goes, well, you guys won't believe this. She goes, well, I found that if I sprinkle cayenne pepper all over my leg, that may help. And then she catches herself, but I do know that you shouldn't put a glob of cayenne pepper in one spot. It has to be evenly distributed through the entire leg.
Yeah,
and
naturally.
Everybody knows that.
Yeah, right?
Yeah.
Says it on the label.
Yeah, exactly. I was like, oh, man. And instantly I started thinking, is this our fault? Like, we didn't educate her? Like, the anticoagulation medication is really necessary? So, anyway, she was dead serious about it. And, I tried to help her understand the importance of taking the anticoagulation. I said, look, it really doesn't seem to be working what you're doing. Let's look at the clot on the ultrasound. It's still there. So anyway, she said she would take it, but I thought, holy cow, I've never heard that. Cayenne pepper
Topically.
Yeah, it's one thing if you take a cayenne pepper capsule or something, but she's like, yeah, and then she goes, well, yeah, I do the cayenne pepper and then I have someone wrap my leg in saran wrap. I was just like, where did you get that?
Miserable in many ways.
Right? So I don't know. Cayenne pepper fixes everything, I guess.
You got to write up a case report now. We know that's not
clearly
that's inferior to Eliquis.
Well, the funny thing was,
we can be confident in that now.
Yeah. I then walked out of there and I was like, am I missing something? Like, is this a real thing? And
some people are so convinced themselves and believable that you start to doubt yourself.
Totally.
Did I miss something?
Yeah, totally.
Is there an article I didn't read?
Yeah, and we all recognize we don't know everything.
No, we don't.
Yeah.
You never want to jump down someone's throat and say, what the heck are they doing? But of course, in my mind, I'm wondering, what the heck are you doing? So,
who told you this?
Yeah.
That's awesome. Well, cool. Aaron, awesome. Thanks for being here.
You bet.
My favorite part of the story, Tyler.
This guy.
Tell us what you learned today.
I learned a lot.
Okay.
That was really good.
I would hope so.
No. I actually really liked gaining some wisdom and knowledge just from you regarding interventional radiology and the growth the advanced practitioner role has taken within that specialty. It's so cool to see the hands-on and how much hands-on you actually are doing. I would not have expected that coming into this conversation. I love the work-life balance. We're always advocating to find that, and I think you found that. It sounds like the pay's sufficient, and hopefully it is scalable, and that's really cool. And then obviously the last bit would be that I found out that topical cayenne pepper is the new essential oil of 2024. So
yes. Go buy some, stock up.
I think it heals all, friends.
That's awesome. Well, how would people connect with you, Aaron? If somebody wanted to follow up and have some more questions, interactions, or wanted to come do some of that shadowing with you now, how would people reach out or connect with you?
I think anyway, I have an Instagram, Facebook, and then even a LinkedIn account. So any of those, they could just message me, and I'd be more than happy to chat with people about whether it be the IR specialty or if they're interested in PA school in general, I'm happy to always answer questions because remember 68 messages on LinkedIn. But Sarah, she saved me, man.
Sarah.
Yeah, are you kidding me?
She better
2
be
people.
listening.
That's right.
Better be listening.
That's right.
That's fantastic.
Well, I'm definitely coming in to see a lumbar puncture. That's what I want to see.
Please.
I think that'd be fun.
Please, come in.
we got to come down.
We'll come track you down.
We're gonna check your
We're down there
digs.
at Utah Valley as well, so we'll come find you.
Come on in.
As far as connecting with our office, Summit Brain, Spine, and Orthopedics, you can find us on Instagram, our YouTube channel, Summit Medical Institute, and my favorite, as always, is come see us in person. Tuesday mornings, 7 a.m. at the Mountain Point Hospital in Lehigh, our interdisciplinary case discussions. We'd love to hear from our listeners as well. Anybody that has some feedback for us, we'd love to hear it. What have you liked? What have you not liked? Who do you want to hear from? And if you yourself want to come chat with us, we'd love to hear from you. Special shout out to our production team as always, putting this together for us behind the scenes. And Tyler, I'm glad you're here with me too, buddy.
Me too.
Appreciate it.
Let's do this again.
Let's do it again. We got some good ones coming up. I'll tease one of them that we talked about with Rocky Mountain. We got one of our head honchos from Rocky Mountain is going to come chat with us.
Awesome.
So stay tuned. Well, this
Rocky Mountain better sponsor us.
Yeah, at this point, man, holy cow. Just keep them coming.
Yeah.
Yes.
Proud alumni, though. We like the institution. They've done really well. But this has been another installment of the Many Minds podcast, where we're encouraging collaborative community healthcare using Many Minds for better outcomes. I'm Alex Davis.
I'm Tyler Murray.
Thanks for hanging out with us. We'll see you next time.
That's a wrap.